Students, in 529 BD, the Catholic Church appointed a group or a segregation of monks, and these monks were supposed to follow the life values and also preach the life values of Saint Benedict. And these monks commonly came to be known as the Benedictines. Now, these Benedictines, whenever they preached or whenever they prayed, they followed a very similar hand signal, that is a hand signal like this, where there is flexion of the two fingers and extension of the rest three fingers. So this was taught to them by Saint Peter himself. And this sign became so popular that even in churches now, whenever a preacher preaches, his hand sign is similar to that used by the Benedictines. And this commonly came to be known as the Benedict's hand or the preacher's hand. Now, this hand sign is not just seen in Benedicts or in preachers. It is seen in another condition, that is when there is an injury of a particular nerve. And that nerve is the median nerve. So whenever there is a median nerve palsy, the hand sign in that patient is similar to that of the Benedict's hand, and hence that sign is called as the hand of benediction. So some believe that Saint Peter himself suffered from median nerve palsy and hence they started following this sign, but there is no true values or true evidence to back that. In this session, we'll be talking about the condition that causes the hand of benediction, that is median nerve palsy. So first, let's understand where the median nerve arises from, and then let's understand the course of the medial nerve all the way from the brachial plexus up till the hand. And only then will we go to all the median nerve palsies or injuries. So the median nerve arises from the middle of the brachial plexus. So it arises from the middle branch of the brachial plexus, and unlike the radial and the ulnar nerve. So we've seen the course of the radial nerve and the course of the ulnar nerve, and we know that in radial and ulnar nerve, there is a lot of crisscross movements or there is a lot of piercing of the anterior and posterior compartment. But the median nerve has a very simple course. It does not cross boundaries. It does not go anterior to posterior or vice versa. Its course is nearly a straight trajectory all the way from the axilla to the wrist. So from the axilla to the way of the wrist, the median nerve moves in a straight trajectory. There is no crisscrossing, there is no piercing of the anterior or the posterior compartment. So a simple nerve course is seen in a median nerve. So now let's discuss the course of the median nerve in the arm. We know that the median nerve arises from the brachial plexus. That is, there is presence of a medial cord and a lateral cord. So they both join to form the median nerve. Now this median nerve in the arm does not travel alone. It has a friend along with it. And that friend is the brachial artery. So the median nerve along with the brachial artery travel right from the axilla all the way up to the elbow. We have to understand the relation of the median nerve to the brachial artery because there is a change. When it is in the axilla, so at the axilla, the median nerve lies lateral to the brachial artery. And as they start walking from the axilla all the way up to the elbow, the median nerve crosses its path to the brachial artery, and near the elbow, it lies medial to the brachial artery. So you have to understand that the median nerve arises when the lateral cord and the medial cord branch joins. That forms the median nerve. And this median nerve travels along with a friend, and that friend is the brachial artery. Now at the axilla, it travels lateral to the brachial artery. And as it travels or walks down till the elbow, there it travels medial to the brachial artery. One more thing we have to understand is that radial and ulnar nerve gives some innervation to some muscles in the arm. But the median nerve is so busy talking to the brachial artery that it does not give any innervation to any muscles in the arm. It directly gives innervations in the forearm. So in the arm, median nerve doesn't give any muscular branches or any sensory branches. So the median nerve is so busy talking to the brachial artery and traveling from the axilla to the elbow that it does not give any muscular or any sensory branches. Now, before it goes into the elbow joint, it gives out one branch, that is a branch to pronator teres muscle. So this branch to the pronator teres muscle is different. So it can give out in different levels. So as you can see here, the median nerve innervates the pronator teres in different levels. So there is a lot of controversy as to which level the median nerve supplies the pronator teres. The only thing that is fixed is that pronator teres is supplied by the median nerve. The level is still debatable. Now we have to understand about few structures that are very close to the median nerve. The first one is the Struthers ligament. So there is presence of a medial supracondylar ridge. So in the distal humerus, there is a medial supracondylar spur. And from that spur, a ligament comes out, and that ligament is the Struthers ligament. That is the ligament of Struthers. Now this ligament of Struthers is important because the median nerve and the brachial artery, I told you that the median nerve and the brachial artery are friends who are roaming together from the axilla all the way up till the elbow. So in some cases, in patients who have this spur and also this ligament of Struthers, these two friends walk below the ligament of Struthers. And it is important because if this ligament of Struthers becomes tightened, it can compress those two structures, that is the median nerve and the brachial artery. That is why it is important for us to know that in certain cases, there can be a Struthers ligament which arises from the outpouching in the distal half of the humerus. So there is a medial supracondylar spur or an outpouching in the distal humerus from which a ligament of Struthers is arising, and through this ligament, both your brachial artery and your median nerve crosses over. And this is important because this Struthers ligament can be a cause for compressive neuropathy. What is compressive neuropathy? So whenever there is any pathology of the Struthers ligament, that pathology can compress both your artery, that is your brachial artery, and your median nerve, and because of that compression, there can be varied degrees of injury. That is, there can be a neuropraxia or there can be neurotemesis or axonotemesis. That when there is compression causing a neurological change, that is called as a compressive neuropathy. So first site is the Struthers ligament. Now the second structure we are going to talk about is laceratus fibrosus. So we know that the median nerve starts at the axilla, and from the axilla it is coming all the way to the elbow with the brachial artery. Once it comes at the elbow, it lies very superficial to the skin, right below the skin. And at this point, there is a structure lying just above the median nerve, and that structure is the laceratus fibrosus. So what is a laceratus fibrosus and where is it arising from? We know that around the elbow joint, there is presence of the biceps muscle. This biceps muscle has an aponeurosis, a modified aponeurosis. That modified aponeurosis is called as laceratus fibrosus, and that lies right above or below the median nerve. So you have the skin, you have the laceratus fibrosus, and right below that is the median nerve. So at the elbow joint, the medial nerve lies very superficial, and it is separated here from the skin by a fascia or an aponeurosis of the biceps. That is laceratus fibrosis. Any cut in this region can damage the nerve. So we know that the median nerve at the elbow joint is lying very superficial. There is a skin, there is a laceratus fibrosis, and right below that is your median nerve. So any cut in that region can damage the median nerve. So that is a point where median nerve is prone for an injury or a cut injury. Also, another thing to remember is that this laceratus fibrosis can also be a cause of compressive neuropathy. So normally this is your laceratus fibrosis. So you can see here the median nerve along with the brachial artery is coming at the elbow joint, and at the elbow joint you have a structure like this. So this marked structure here, that is the aponeurosis of the biceps, that is called as laceratus fibrosis, is lying above the median nerve. Now imagine that there is a thickened laceratus fibrosis. So because of a certain pathology, this laceratus fibrosis has become thickened, and because of that thickening, there can be compression on the median nerve causing a compressive neuropathy. So this is the second site for compressive neuropathy. The first one we talked about was the Struthers ligament. The second one is the laceratus fibrosis. So these two sites, there can be compressive neuropathy of the median nerve. So now at the forearm, so we know that it passes through the Struthers ligament, also that it passes through the laceratus fibrosis. After that, after passing the elbow, it comes into the forearm. Now first, After it passes the laceratus fibrosus, the median nerve passes between the two head of the pronator teres. So you can see here in this diagram here that there is presence of the two heads of the pronator teres, and the median nerve, after it comes below the elbow, is passing between the two heads of the pronator teres. Next, it pierces and enters the forearm. So this is its entry into the forearm. After it goes between the two heads of the pronator teres, it is entering the forearm. And in the forearm, it runs right between two structures. One is the flexor digitorum superficialis and another is the flexor digitorum profundus. So let's understand these structures. The flexor digitorum superficialis, as the name suggests, it's a flexor and it supplies the digits and it lies superficially. So it is a flexor that is supplying the digits and it is lying superficially. The second muscle is flexor digitorum profundus. So it is also a flexor, it also supplies the digits, but it is profundus. Profundus meaning it is in the deep plane. Profundus in Latin stands for deep. So flexor digitorum profundus is a deep structure, flexor digitorum superficialis is a superficial structure, and right below these two muscles, the median nerve passes. So that is how it enters the forearm, and after it passes between these two structures, it supplies all the flexors. So once it pierces and enters the forearm, in the forearm, it runs between the flexor digitorum superficialis and the flexor digitorum profundus. So here you can see that there is presence of the flexor digitorum profundus and the flexor digitorum superficialis. And this median nerve passes right in between. So it forms a sandwich where the superficial part of the sandwich is the flexor digitorum superficialis and below is the FDP. And right between it is the median nerve. Now there is one more thing you need to know. The median nerve, I told you, passes between the two heads of the pronators, and after it passes the true head of the pronators, it goes to lie between the FDS and the FDP. But the median nerve, as it passes out of the pronator teres head, gives out a branch, and that branch is called as the anterior introitious nerve. So we know that there is one head of the pronator teres and there is another head of the pronator teres, and the median nerve is passing between these two heads. Now once it passes through these two heads, it goes to lie between the flexor digitorum superficialis and the flexor digitorum profundus. This nerve is called as the anterior introitious nerve. So what was previously called as the median nerve will branch out to form the anterior introitious nerve. So when it is the median nerve, when it is between the pronator teres heads, it gives out the flexor carpi radialis branch, the palmaris longus branch, and the flexor digitorum superficialis branch. But after coming out of the pronator teres, it gives out an important muscular branch, and that muscular branch is the anterior introitious nerve. Now this anterior introitious nerve that is now passing between the FDS and FDP will give out branches, that is the flexor pollicis longus, the pronator quadratus, and the flexor digitorum profundus of the lateral two fingers. So very important to understand that the flexor muscle, so we have some superficial flexor muscles, that is the flexor carpi radialis, that is FCR. You have the palmaris longus and also the flexor digitorum superficialis. So these are your superficial structures. You also have deep structures, that is the flexor digitorum profundus, also the flexor pollicis longus, and the pronator quadratus. So let's understand that the superficial flexor muscles, that is the flexor carpi radialis, the pronator longus, and the flexor digitorum superficialis. So these superficial structures are supplied by the median nerve itself. And the deep structures, that is the flexor digitorum profundus, the pronator flexor pollicis longus, and the pronator quadratus is supplied by the muscular branch of the median nerve, and that is the anterior introitious nerve. Another point that we have to understand is not the complete FDP supplied by the median nerve. The FDP has a dual nerve supply. So the lateral two fingers that is supplying the FDP, the innervation for that is given by the anterior interosseous nerve. The rest of the finger, the innervation of the FDP is given by the ulnar nerve. So it is very important to understand that the FDP has a dual nerve supply. One is the median nerve, that is the anterior interosseous nerve of the median nerve, and another is the ulnar nerve. So now let's look at the diagram of how the median nerve is traveling in the forearm. So you can see here the median nerve coming at the elbow joint is now going between the pronator teres. So you can see here it is traveling between the two heads of the pronator teres, and after it comes out, it forms the anterior interosseous nerve. So it is traveling all the way up till here, and then it gives out a muscular branch, and that is the anterior interosseous nerve. This anterior interosseous nerve is traveling between the flexor digitorum profundus and also a part of the flexor digitorum superficialis. So these give out different branches. The anterior interosseous nerve supplies the deep branches, that is the FDP, the pronator quadratus, and the flexor pollicis longus. This median nerve gives branches to the superficial muscles, that is the flexor digitorum superficialis, flexor carpi radialis, and the pronator teres. Now let's understand what happens to the median nerve after it crosses the forearm. It goes below the flexor retinaculum. So in the wrist, we have a structure that is called as the flexor retinaculum, and the median nerve passes right below the flexor retinaculum. We know that in carpal tunnel syndrome, the flexor retinaculum tightens, and that is what presses the median nerve. So we know the course of the median nerve at the wrist very well. That is, it is going below the flexor retinaculum. But just before it goes below the flexor retinaculum, it gives out a very important branch, and that is the palmar cutaneous branch of the median nerve. So this branch is given out just before it goes under the flexor retinaculum. So this is a pure sensory branch. So it has no motor innervation. It is a pure sensory branch that is arising just before the median nerve goes under the flexor retinaculum. Now in the hand, after the median nerve passes below the flexor retinaculum, what happens to the median nerve? So after exiting the flexor retinaculum, it gives out a recurrent motor branch. And this recurrent motor branch supplies the thenar muscles. So let's understand what is thenar, what is hypothenar. So in the hand, we have a major projection here in the palm. That is the thenar surface. And this is the hypothenar surface. So the flexor retinaculum, after the median nerve exits the flexor retinaculum, it comes to lie at the thenar region. It gives out a very important branch, that is the recurrent motor branch. This recurrent motor branch supplies the thenar muscle. So what are these thenar muscles? That is your flexor pollicis brevis, your abductor pollicis brevis, the opponens pollicis, and also the lumbricals of the first and second. So your thenar muscles are the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis. Also, it gives out branches to the lumbricals of the hand. So lumbricals are important in finger coordinations. So two lumbricals, that is the first and the second lumbricals, are supplied mainly by the median nerve. The rest are supplied by the ulnar nerve. So we have to understand the differentiation. Not all lumbricals are supplied by one nerve. The lumbricals of the first and the second finger are supplied mainly by the median nerve. The third, fourth, fifth mainly are supplied by the ulnar nerve. Now after it divides, it forms the digital branches. So the end course of the median nerve is to form the digital branches. So in the hand, we have understood that first it courses underneath the flexor retinaculum, and after it comes out from the flexor retinaculum, it gives out a very important branch, that is a recurrent motor branch. Now what is the function of this recurrent motor branch? It is important for this thenar muscles and also for the first and second lumbricals. What are these thenar muscles? That is your flexor pollicis brevis, the abductor pollicis brevis, and opponens pollicis. In the finger, that is the first and the second finger, it helps in supplying the lumbricals, and it ends by forming the digital branches. So now let's see the diagram of how the median nerve is passing through the hand. I told you that the first structure that it encounters in the hand is the flexor retinaculum. So you can see here this structure that you see at the proximal aspect of the wrist, this is the flexor retinaculum. So the median nerve is going right below the flexor retinaculum, and once it exits the flexor retinaculum, it gives out a branch, that is the recurrent branch, and this recurrent branch is now supplying this junction. This junction is called as the thenar junction, or the thenar muscles are seen here. These thenar muscles are supplied by that recurrent branch of median nerve. And what are these thenar muscles? That is the flexor pollicis brevis, the abductor pollicis brevis, and also the opponens pollicis brevis. So these three muscles that form a part of the thenar muscles are supplied by the recurrent branch of the median nerve. The other muscle that is supplied by this recurrent branch is the lumbrical. So the lumbricals of the first and the second finger are also supplied by the recurrent branch of the median nerve. Now, after it gives out these branches, the median nerve forms the digital nerve. So you can see here, there is digital nerves that are passing through the finger, and these digital nerves are the median nerves. So the median nerve ends by forming the digital nerves. Now let's understand the sensory supply. So we've talked about all the motor muscles that are supplied by the median nerve. Let's understand the sensory innervations of the median nerve in the hand. We mainly have two sensory branches. One is the digital nerves, that is the end product of the median nerve. Also, we have another branch that we talked about, which is given out before it enters the flexor retinaculum, that is the palmar cutaneous branch of the median nerve. So the palmar cutaneous branch of the median nerve supplies this thenar junction and a little more distal to it. So this much area in the palm is supplied by the palmar cutaneous branch. Now the digital cutaneous branch supplies 3.5 fingers. So it supplies the first, the second and the third finger, and also half of the fourth finger. So this much in the palmar region is supplied by the digital cutaneous branch, and also the distal aspect. So that from the distal interphalangeal joint, these three areas of the finger in the dorsal surface are also supplied by the digital cutaneous branch. So this is the sensory innervation of the median nerve in the hand. So we have two types. One is the palmar cutaneous branch that supplies mainly the palmar surface at the thenar junction and little more distal to it. And the digital cutaneous branch supplies 3.5 fingers in the palmar surface, and in the dorsal surface it supplies 3 fingers right up till the DIP joint. So why is this important for us to know why two nerves are supplying different areas? Because if the injury is occurring distal to the flexor retinaculum, then only these digital cutaneous branches are gone. So the patient will feel hypoesthesia only in these green junctions, not at this blue junction. But if the median nerve injury has occurred before it is going into the flexor retinaculum, before it is giving out the palmar cutaneous branch, then we know that the hypoesthesia is occurring in both this blue region and also this green region. So very important to understand the level of the injury of the median nerve. Now let's understand the applied aspects of the median nerve injury. So till now we have discussed about the course of the median nerve right up the axilla to the wrist. We've also talked about where the sensory supplies are. Now let's understand what happens when there is a median nerve palsy. And this median nerve palsy can occur because of two things. One is if there is a compressive neuropathy, if some structure is compressing the median nerve. Second is when there is a median nerve injury. So imagine there is a cut injury of the median nerve. So in these two cases, what happens to the median nerve and what are the relations seen in the different muscles? So first, let's understand the tests that we do for the median nerve, and then we can go into the compressive neuropathies and the injuries. So the median nerve tests that are done are the hand of benediction. So we've already talked about the hand of benediction. That is, the patient has an attitude of the hand like this, which is commonly seen in benedicts or in preachers. So there is these 3 fingers which are extended. These 2 are flexed. There is also pointing index. So we talk about hand of benediction. There is also an attitude of a pointing index that is seen in median nerve injuries. There is an Ochsner clasp test. There is an ape thumb deformity that can be noted. There is a duck bill or a Kilo-Nevin sign and a pen test. So let's understand each of these signs individually. So first, let's talk about the hand of benediction. So hand of benediction is the attitude of the hand of the Pope while greeting. So the popes or the Benedictines, whenever they greeted or whenever they did preaching, they had their hand like this. And in median nerve injury, the hand is very similar. That is why it is called as hand of benediction. So why is the hand like this is something we have to understand. So this benediction hand, the first, second, third FDPs are mainly involved. So we know that the median nerve mainly supplies the FDP of the first and second and sometimes also of the third. So the first, second, third flexor digitum profundus is involved. The other flexors, the FDP of the fourth and fifth finger, are supplied by the ulnar nerve. So whenever you're trying to flex the hand, you know that the ulnar nerve is working, but the median nerve is injured. So these two fingers, because the ulnar nerve is proper and because the FDP of these two fingers are supplied by the ulnar nerve, will be able to flex. But these three fingers will not be able to flex because the FDP and the FPL and other flexor muscles of these three fingers are damaged. So because the FTP of the first, second, also the third is damaged, that is why whenever a patient tries to clasp his hand becomes something like this. So this sign is called as the hand of benediction because the first, second, third FDP is involved. Also the FPL, FPB, which is a thenar muscle, and also the lumbricals are involved. So because the FDP, the FPL, FPB and the lumbricals are involved in these three fingers will not be able to flex. Similarly, these two fingers will be able to flex because the FDP of the fourth and the fifth are supplied by the ulnar nerve. So that is why you get a similar sign, that is hand of benediction. Now, in reality, whenever you see a patient of median nerve injury, he won't have a hand like this. Most commonly, the hand that you see is something like this. And that is why it is called as a pointing index. So, it looks like someone is pointing at another person. So, it is called as a pointing index. So, why is it seen like this and not like this? This is because we know that the thumb and the second digit, the FDP is injured. So, the flexor tendons are injured and that is why they won't be able to flex. But why is the third finger having a weak flexion? So, you can see the middle finger can weakly flex. Why is that? That is because the flexor tendons of the thumb and of the first finger are phylogenetically higher or superior. That is why they have a single tendon that is coursing by. So the tendons of the second digit and the tendons of the thumb are individually passing by. But the tendons of the third, fourth and fifth, they move together. So this three tendons move in a common sheath. That is why even though the third finger's flexion or FDP is damaged, the other two fingers FDP or the flexor tendons are normal. So because they have a common sheath and because of the common sheath, there is some amount of pull that is generated even at the third finger. That is why there is a weak flexion of the third finger. So let's understand why do we have a pointing index and not a benediction finger? Because these two flexor tendons, that is the thumb and the first digit, they have an individual or a single flexor tendon. The flexor tendon of the third, fourth and the fifth finger have a common sheath. And because they have a common sheath, whenever these two tendons flex, that common sheath will also pull the tendon of this third finger, that will cause a weakly flexed third finger, and that is why you have a pointing index. So hand of benediction also can be seen, but most commonly we get a hand like this, where there is a weak flexion of the third finger, and that is the pointing index. The next is the Ochsner clasp test. So in this, when the patient is asked to clasp the palm and the fingers of both the hands together from far away, so whenever you ask him to clasp his hand together, you'll be able to see that one of the fingers, these two fingers are not able to flex. So they are pointing outwards. This is similar to a pointing index. So where these fingers are pointing outwards. And this is a sign of a median nerve injury. So this sign is the Ochsner clasp test. We are asking him to clasp his hands like this. And whenever he clasps his hand like this, the two fingers are pointing outwards. And that is a sign of a median nerve palsy. Next is an ape thumb deformity. So students, you have to understand that in humans, we have a very distinctive feature. All the other species, they are not able to move their thumb in multiple directions. But we human beings have a very important feature, that is the opposition of the thumb. Our thumb is so unique that we can move the thumb in any direction. So we have multi-axial movements of the thumb. But in a median nerve injury where the thenar muscles are getting damaged, our thumb also becomes uniaxial. So we are not able to do the opposition of the thumb because opponents is damaged. The thenar muscles are damaged, and that is why the thumb will not be able to move in multiple direction. Our thumb will become like any ape's thumb, which has a single movement of the thumb. So it is an ape thumb deformity. So when the thumb is nearly in the same plane as the other fingers. So we know that normally a thumb can move in multiple directions. The finger cannot move in multiple directions, but the thumb can move in multiple directions. But when the thumb starts to move in a single plane, like the other fingers, that is called as an ape thumb deformity. That is, there is inability to oppose or flex the thumb. There is a significant wasting of the thenar muscle. So we know that the median nerve, that is a recurrent branch of the median nerve, is supplying these thenar muscles. And this thenar muscles, mainly the opponent's muscle, is responsible for the opposition of the thumb. So when the median nerve is injured, the opponents is damaged and even the thenar muscles are damaged. That is why the opposition of thumb is lost, and also this thenar muscle becomes wasted. So there is wasting of the thenar muscles and there is loss of opposition of the thumb, leading to a ape thumb deformity. So next is the duckbill or the Kilo-Nevin sign. So as kids, do you remember making these shadow impressions? So we made these shadow impressions of a duck bill. So the shadow impressions was made by keeping the hand like this. So this sign is only possible when the median nerve is intact. So to do this duck bill sign, we need the FDP and the FPL pull. So to get this finger, we need the FDP, and to get this finger to move, we need the FPL pull. So only when the FDP and the FPL are intact are we able to do this duck bill sign. So whenever there is loss of FDP and FPL, the hand becomes somewhat like this. So that is the duckbill or the Kilo-Nevin sign, and this is mainly seen when there is an anterior interosseous nerve injury. So in anterior interosseous nerve injury, both your deep muscles, that is the flexor pollicis longus and the flexor digitorum profundus, is injured, and that is why the hand cannot be made into such a fashion. The hand goes into a movement like this. So this is a classic sign of an anterior interosseous nerve injury. So a duckbill or a Kilo-Nevin sign is when you do a O sign. So this is the O sign. So when you can't do this O sign, when the hand goes into a duckbill kind of sign, that is when there is an AIN injury, that is anterior interosseous nerve injury. Commonly seen when there is supracondylar humerus fracture in children. So when there is a supracondylar fracture humerus, that is when anterior interosseous nerve injuries can be commonly seen. So next, let's talk about the pen test. So the pen test is to test the abductor pollicis brevis muscle. So it is a thenar muscle, that is abductor pollicis brevis. So you keep a pen away and higher from the hand, and you ask the patient to touch the tip of the pen with the thumb. So you keep the pen higher and above the thumb, and then you ask the patient to touch it. So if the abductor pollicis brevis muscle is working, then the patient is able to touch the pen tip. But if the abductor pollicis brevis or the thenar muscles are not working, whenever the thenar recurrent branch, that is the median nerve, is damaged, in such cases the pen test will come positive. That is, patient is not able to touch the tip of the pen. Okay, so that is a sign of an abductor pollicis brevis injury caused due to a median nerve injury. Now let's understand the compressive neuropathies. So we've discussed the course of the median nerve. So let's understand at what points can the median nerve get compressed, leading to a compressive neuropathy. First, at the wrist. So I told you that the median nerve, after it gives out its flexor branches in the forearm, goes right below a structure called as the flexor retinaculum. So due to various reasons, if the flexor retinaculum tightens, that will cause compression of the median nerve at the wrist region, and this is commonly called as the carpal tunnel syndrome. So this is the most common compressive neuropathy of the median nerve. Next, in the elbow. So in the elbow, we know that the median nerve passes between the heads of the pronator teres, Before that, it lies right below a structure called as laceratus fibrosus, which is the modified aponeurosis of the biceps. So it can get damaged or it can get compressed at the pronator teres. Also, it can get compressed at the laceratus fibrosus. Also, it goes down between the FDS and the FDP. So it is sandwiched between the FDS and FDP. So at the arc of the FDS, it can get compressed. So even the FDS arch is a site for compressive neuropathy. So at the elbow, three structures. One, between the heads of the pronators. Another is the modified aponeurosis of the biceps, that is the laceratus fibrosus. The third is the arch of the FDS. In the arm, I told you there is an outpouching at the humerus. From that outpouching, sometimes a ligament comes out, that is the Struther's ligament. So when the median nerve passes under this Struther's ligament, if because of any reason that Struther's ligament tightens or bulks up, that can lead to compression of both the median nerve and its friend, that is the brachial artery. So there is compressive neuropathy at the arm at the site of the Struther's ligament. Now coming to the median nerve injuries. So we have to understand the different levels at which the median nerve can be injured, and commonly we've divided this median nerve injury into two types. One is a high median nerve palsy and the second is the low median nerve palsy. So we know the course. We know that it comes out of the brachial plexus and at the arm it gives no branches. And when it comes below the elbow, it passes between the pronator teres, it gives out branch to the pronator teres, it gives out branch to the superficial flexor muscles and the deep flexor muscles. And at the wrist joint, after it passes below the flexor retinaculum, it gives out branches to the hand and mainly the thenar muscles. So whenever there is an injury above the wrist joint, that forms the high median nerve lesion. But whenever the injury is below the wrist joint, so you can see here, this is the junction of the wrist joint, after which it gives out the palmar cutaneous branch just before it goes into the flexor retinaculum, and after it passes below the flexor retinaculum, it gives out the three thenar muscles, it gives out the first two lumbricals, and it also gives out certain digital nerves. So that if there is an injury right below that region where it is giving out the palmar cutaneous nerve and also it is going below the flexor retinaculum, that forms the low median nerve lesion. So you have the high median nerve lesion and you have the low median nerve lesion. So let's find out how do we differentiate a medial nerve injury occurring in the high region and in the low region. Now a high medial nerve lesion is caused because of an elbow dislocation, a forearm bone fracture, a stab injury to the elbow. So I told you at some point near the elbow, when it is at the laceratus fibrosus junction, the medial nerve is very superficial. So if there is any stab injury right at that junction, that can cause a medial nerve injury, and that type of medial nerve injury forms the high medial nerve lesion. Also a gunshot injury. So in elbow dislocation, forearm bone fractures, in stab injuries at the elbow, and in gunshot injuries, there is a high median nerve injury. And in high median nerve injury, all the muscles are involved. Maybe the muscles of the forearm and the muscles of the hand. That is why you have loss of thumb opposition, because thumb opposition is caused by the thenar muscles. Also, the FCR, PT, that is the pronator teres, pronator quadratus, are all paralyzed. So all the long flexors, the superficial and the deep flexors and the muscles of the hand, all are paralyzed, and that is why there is presence of a Poynting's index. So I told you, if all the long flexors are damaged, that will give a hand attitude somewhat like this. That is the Poynting's index, or in some cases also called as hand of benediction. So these two signs are seen in high medial nerve lesion because the long flexors are damaged in high medial nerve palsy, and that is why it will give out an attitude like this. Now coming to low median nerve palsy. So low median nerve palsy is whenever there is a cut injury to the wrist or there is a carpal dislocation. So any cause distal to the wrist joint. So where the palmar cutaneous nerve branch is given and then it is passing below the flexor retinaculum, in that junction if any injury occurs. So we know that the carpal bones are very close to the median nerve and the flexor retinaculum. So if there is a dislocation of the carpals, that can cause a median nerve compression or a median nerve injury. So in carpal dislocations or in patients, whenever they're doing a cut to the wrist, so in patients attempting suicide, whenever they do a cut injury to the wrist, that can damage the median nerve because the median nerve is right below the flexor retinaculum. So any cut at that junction can cause a median nerve injury, and that median nerve injury is a low median nerve palsy. So in a low median nerve palsy, the long flexors are already supplied. So you know that the long flexors are given by the median nerve and by the anterior interosseous nerve, and these branches are given out in the forearm. So they are still intact. So since the long flexors are spared, that is why the pointing's index is absent. So the hand won't be in an attitude like this because the long flexors are spared, are normal. Because of this, the hand won't have a pointing's index. So in this case, pointing's index is absent. Also, there is loss of sensation because the palmar cutaneous branch is damaged. So we know that it is occurring right at the junction where the palmar cutaneous branch is given and it is going under the flexor retinaculum. So there is damage to both the palmar cutaneous branch and the digital branch. So the sensory damage has occurred in both these areas. That is why there is loss of sensation of the hand, mainly at the palmar cutaneous branch and the digital nerves. Another thing is because the abductor pollicis brevis, flexor pollicis brevis and opponens pollicis, these are your thenar muscles. So where are these thenar muscles being supplied by? They are supplied after the nerve, median nerve, comes out of the flexor retinaculum and gives out a recurrent motor branch. So when there is an injury to the wrist junction, you know that the thenar muscles, that is a recurrent branch, is damaged. That is why these three muscles, abductor pollicis brevis, flexor pollicis brevis and opponens pollicis, are damaged, and that is why there will be thenar eminence wasting and patient is unable to abduct the thumb. So abduction of the thumb and wasting of the thenar muscles is noticed. So in a low median nerve palsy, one thing that is absent is this Ponting's index. So the long flexors are intact. That is why Ponting's index is absent, but sensory distribution or sensory damage is there because both your sensory branches, that is your palmar cutaneous branch and your digital nerves, both are damaged. So there is complete loss of medial nerve sensory supply, and also because the thenar muscles are damaged, there is loss of abduction of thumb and there is muscle wasting at the thenar junction. Now coming to the summary of a median nerve palsy, first we talked about the anatomy, that is the course of the median nerve. I told you that the median nerve starts right at the brachial plexus, where the medial cord and the lateral cord joins up to form the median nerve, and this median nerve along with its friend, that is a brachial artery, courses from the axilla all the way up till the elbow, and it is so busy talking to the brachial artery that it forgets to innervate any muscle in the arm. So there is no supply to any muscles in the arm. After it comes at the elbow, sometimes it passes below the struthus ligaments, and also it goes through a structure called as the laceratus fibrosus. After that, it pierces the pronator teres two heads, comes out, gives out a major supply, that is a motor branch, that is anterior interosseous nerve, and these two nerves, that is a median nerve and the anterior interosseous nerve, supply most of the superficial and the deep flexors. And after that, right when the wrist region occurs, just below the flexor retinaculum, it gives out a very important sensory branch, that is a palmar cutaneous nerve. After that, it goes below the flexor retinaculum and gives out a recurrent branch, that is a motor recurrent branch, which supplies the three thenar muscles and also supplies the lumbricals or the first and the second finger, and it ends by forming another sensory branch, that is the digital branch. So that was the anatomy, and that was about the muscles that are supplied by the median nerve. Next, talking about the sensory, we know that there are two sensory branches. One is the palmar cutaneous nerve, another is the digital nerve. So the palmar cutaneous nerve mainly supplies the thenar junctions at the palmar region, and the digital nerve supplies the dorsal part, that is till the DIPs of the three fingers, and also supplies the palmar part, that is 3.5 fingers of the thumb, the first, the second, and some part of the third. So that is supplied mainly by the digital nerve, and that is a sensory supply of the median nerve. Next, coming to the median nerve tests, First, we talked about the hand of benediction. So you can see a hand attitude somewhat like this. But practically, the hand that you see is somewhat like this because there is a common sheath for the third flexor. Because there is a common sheath, that sheath will pull, leading to certain weak flexion of the third finger, and that is why you will have a Ponting's index. So hand of benediction, Ponting's index, and whenever you ask such patients with median nerve injury to clasp their hand, you will see that the index finger is pointing out. So this is called as the Ochsner clasp test. Also, another thing that you'll notice is that the opposition of the finger is lost. So the thumb is in a single plane. It is not moving in an opposition motion. So there is an ape thumb deformity. Another thing that you notice is that there is a pen test that you can do for thenar muscle. So we know that these thenar supply muscles help in abduction of the finger. So you ask the patient to touch the pen tip, which is kept right above and a little lateral to the thumb, and then you ask the patient to touch the tip of the pen. If the patient is not able to touch the tip, that is when you know that the abductor pollicis brevis is damaged. This is because of a median nerve palsy. So that was about the median nerve tests. Then we talked about the compressive neuropathies. So the compressive neuropathies can occur at the Struthers ligament. They can occur at the laceratus fibrosus. They can also occur between the heads of the pronator teres and also at the flexor digitorum superficialis arch. More common compressive neuropathy is seen at the wrist, that is at the flexor retinaculum junction, and that is called as the carpal tunnel syndrome. So that was about the compressive neuropathies. Then we talked about the median nerve injuries. So median nerve injuries is divided into two: high median nerve injury and low median nerve injury. In high median nerve injury, it can occur at the arm, it can occur at the forearm. Low medial nerve injury occurs right at the wrist junction, where it is giving out a palmar cutaneous nerve branch and going below the flexor retinaculum. So when there is damage distal to that, that is called as a low median nerve palsy. So what is the difference? Mainly the difference is that in high median nerve palsy, the long flexors are damaged. In low median nerve palsy, the long flexors are spared, and because of that, in high median nerve palsy, you'll have a hand like this. That is a Ponting's index. But in a low median nerve palsy, there is no Ponting's index seen, but there is still sensory damage and there is damage to the thenar muscles. So in low median nerve palsy, you won't be able to abduct the thumb and there will be thenar muscle wasting and whole of the sensory is lost. In high median nerve palsy, all this is there. Along with that, there is a Ponting's index and all the functions of the long flexors are also lost. So that is the difference between a high median nerve palsy and a low median nerve palsy. So we've discussed about the course of the medial nerve and all the applied aspects, that is the compressive neuropathies and the injuries to the median nerve. That's all for this session.